Hey everyone, sorry, we're going to give it one more minute. There's at least one other advisory council member who we know was planning to join, and just in case he's having technical difficulties, I want to wait because I really like to do a round of introductions to kick off, since this is our first time with sort of a critical mass with some new members. So let's just give it, like I said, one more minute. And then okay, sorry all. We are having a little technical difficulty, but Kaylee's going to try and work on it on the side, and maybe we can jump in and get started. Just trying to decide that, like I said, I really wanted to do a set of intros for everybody. So trying to balance that. Maybe I can start with a couple slides on kind of background on LD2196, and then potentially pause before we kind of move more into discussion to do those intros. Today's agenda is fairly short, as you saw from the slides that I sent around in advance. I know during our last meeting, there was desire to kind of take some more time and talk about the substance of this bill, which was sort of built on and reflects the policy framework that we put together and presented to the HCIFS committee back in the fall. So we just wanted to devote this meeting to that topic. I know it's top of mind for many members and certainly is for us as well. Before we get into kind of the section by section and some conversation, I just wanted to come back to this slide, which I know you've seen in a few different presentations in the past, but that I think summarizes our thinking as we were putting together the framework for policy and helping to prioritize and make determinations about the structure that it would take. The first I know is familiar, and we've talked about a lot in this group, trying to come up with solutions where in the short term, knowing that we don't have a lot of partnership necessarily on the federal government at the moment, that avenues that might have been open to us in other structures like waivers are not so much of a realistic possibility right now. So really trying to think about work that we can do in the state where it's not necessary for us to ask permission or kind of get federal approval or have federal funding involved.
I'm sorry. I know we've seen that before, but I'm not sure that we've actually really talked about that before.
We can pause there.
And I think that is just, I think I certainly understand the rationale. And I would just want to acknowledge that creating a system, a small state that is heavily reliant on federal payers We had over 70% of our, 71%, I think, of our patients in Maine Medical Center in the last month were reliant on federal payers. And I think we have to acknowledge that trying to do something absent state and federal government, but primarily federal in the oldest state in the nation, presents a whole different set of challenges, and one that we have not had a conversation about. So I just wanted to share that. I think it's relevant to this conversation.
Yeah, and I guess I'd say, I don't think that this ignores federal context. And I do think that there are challenges. I mean, this has come up several times when we've been in front of the committee, for example, on public option bills. That yes, the ability to do a single payer or design a solution without those programs at the table, I think is really challenging. And I think that we've been clear about that. At the same time, I think in this context, certainly the direction that I've had from the legislature is
but you can't get on mic or video. Is that the question?
Yeah, I don't. I see somebody is showing some slides. It looks like.
we've got you now, Dr. Evans. Kaylee just muted, but I think you're on with us now. I think you should be all set.
Microphone is on.
We can
Speakers.
hear you, Dr. Evans. This is Meg. Hi there.
Hi. I just can't see anybody, but I can hear you.
Okay, if you can see, we're sharing some slides right now, so that might be why. I think if we pull these down, you'll see the folks in the room, but you've got us both, some folks here physically in the room, and then several people on virtually as well.
Okay. All right. So okay. So I'll just go through the slides. At least I can hear what's going on.
Okay, perfect. Yeah, we were just discussing a couple kind of background slides, and then I think we'll pause and do a round of introductions because I know it's your first meeting and it's Amanda's first real meeting so far. So we'll pause there and let everyone get a sense of who's on the call, and then jump into some further discussion.
Okay. All right. I'll stay on.
Okay, wonderful. Thank you.
Thank you. Bye-bye.
So I was just going to say, I think also though, the legislature certainly, their direction to me hasn't been, because there are challenges at the federal level, we're going to wait and not try to do work at the state level. So I think we're trying to find the balance there of what can be accomplished, and it's certainly not to ignore or not consider the federal context.
And just to, I think it would be helpful for me to understand when you say the legislature, talking about the HCIFS committee.
I would say, yeah.
And your communication with them is primarily in the public settings, or is there something separate?
Yeah, I'm specifically thinking about, I was on mic in front of them a few different times in committee last year talking about other bills, including market oversight. And they said, we want you to come back and talk about big ideas. They also sent a letter to the office, which is what prompted the presentation that I gave, where they really said, bring us big ideas that have a big impact.
Thank you.
Okay. So then thinking about reach of policy, the maximum number of people possible. Again, there's trade-offs here. We know narrower applications of policy are less disruptive maybe to the system, but we came in really wanting to think about there being a lot of people who are in need of relief right now and wanting to reach and create policy that has an impact for as many of them as possible. Prioritizing cost relief for consumers, which I feel has always been at the heart of what the office was designed to do. And again, very much a focus when I have conversations with the HCIFS committee. I think that is where a lot of their minds are, and the legislature sort of more broadly. And then finally, balancing that cost relief with investments in upstream services that we've heard from members of this group and others are undercompensated, particularly in some cases by commercial insurers. So trying to find that balance, that it's not all about maximizing cost relief, that's core of the focus, but that we're looking to accomplish some other priorities or find ways to kind of rebalance spending, not just reduce it. And then just as a reminder of the framework, I won't spend too long on this because I do think folks have seen this several times. Talked about setting limits on commercial hospital facility prices, combination of caps on the prices themselves for services and a cap on the growth of prices, and then doing three things with essentially the avoided claim costs from those caps, which are reducing healthcare costs for families and businesses. As I said, this concept of rebalancing spending so that we're investing more in primary and behavioral health care, and then reducing administrative burden through changes to prior authorization. So just as a reminder, that's the big picture. I think I'll wait and we go into more detail on this in the next slide, so maybe we can hold and sort of discuss each of these in isolation. But if it works for folks now that we've got, I think everyone we were expecting, maybe we can pause there and do a round of introductions if that works. And I can kick off. I think everyone knows me at this point, but just in case, Meg Garrett Reed, Executive Director of the Office of Affordable Healthcare. We usually have Katie Seneschal with us, but there was another meeting that we needed some coverage of, so she's doing that right now. Got Kaylee with me.
Hi everyone, Kaylee Shea, Policy Analyst with the Office of Affordable Healthcare.
Great, I'm Trevor Putnaki. I'm with the Healthcare Purchaser Alliance of Maine, representing employers and public trust of the state, and the chair of the advisory council.
Katie Fulham Harris with Maine Health.
Perfect. And then I'll just go through who I see on my screen. So Amanda, would you like to go next?
Sure thing. So my name is Amanda Burgess. Along with Dr. Evans, I'm a newbie on the Advisory Council. I'm currently part-time faculty at the University of Southern Maine, and my background is in rural health-focused research.
Wonderful. Thanks so much. And welcome. Excited to have you. Maybe we can stick with other new members. And Dr. Evans, do you want to introduce yourself next? Hoping you can still hear me and let us know. We can take you off mute if that's helpful. Oh, I think you're still muted right now. Strange. I don't know why. For some reason, we can't hear you. Maybe I'll give you a minute and we can loop back at the end, Dr. Evans, if you're able to come off mute. But I'll go to Randy next.
Good afternoon. I'm Randy Clark. I'm the president of Northern Lights, CA Dean, Mayo, and Sebastopol Valley Hospital. Also still the president of the recently closed Inland Hospital.
Thank you, Randy. Kate, Andy?
There, Kate Endy. I'm the policy director at Consumers for Affordable Healthcare and also the vice chair for the Advisory Council. Thanks.
Thanks, Kate. Maureen?
Good afternoon, Maureen Hensley Quinn, Senior Director of Coverage, Cost, and Value at the National Academy for State Health Policy, which is a national nonprofit, nonpartisan organization that focuses on states and health policy. My background very specifically is on supporting states to cover as many people as they can in the service of access to healthcare, which has also included looking at healthcare costs and value. And I'm also new to this council.
Wonderful. Thanks, Maureen. Dr. Evans, I think I see you off mute now. Want to try again?
Yeah, so finally, thanks so much. I am Dr. Richard Evans. I am a recently retired general and colon and rectal surgeon in Dover Foxcroft. I have an extensive background relative to healthcare. I am Maine senior delegate to the American Medical Association, a past president of the Maine Medical Association, a veteran, a former hospital and medical group commander. So I am happy to be joining you guys for this meeting today.
Wonderful. Thanks, Dr. Evans. I'm very happy to have you as well. Kevin Lewis.
Hey, good afternoon. Kevin Lewis. I'm the CEO of Maine Community Health Options, Maine's domiciled nonprofit health plan here. Operating in the individual and group markets, so ACA and commercial lines of business, self-insured as well. Thank you.
Well, thanks, Kevin. And finally, Jordan.
Hey everyone, Jordan Rhodes. I'm the Director of Research and Policy Analysis at Maine DHHS.
Thank you. And yeah, we've got a pretty full complement of members at this time, though a few weren't able to join us. So we have Representative Ann Graham, Mallory Shaughnessy, and Renee Fay LeBlanc are the three members who aren't able to be here today, just so that the new members know there are some additional faces. And as folks made reference to, Amanda and Dr. Evans are our newest members, but both Randy and Maureen were confirmed just this fall too. So have had a couple meetings to kind of get their feet under them, but are also quite new to the work of the council. And we do have one other vacancy. So Jordan is an ex officio member representing DHHS, and we do have a seat for DAP's representation that they know has a vacancy right now and are working to fill, but just to give kind of folks a little bit of a sense of who's who. Perfect. Thanks for taking the time to go through that. I will say I wondered if we should do an icebreaker. I listened into the Primary Care Advisory Council, and they did what Olympic sport you would like to participate in if you had a choice, but I let everybody off the hook. Interest for this one. Maybe in the future we can come up with a fun one. Yeah, it was an interesting thought exercise.
You know, many people want to be curlers.
Yeah. I do think the question of whether you get any skill imbued in you in order to do the sports makes a difference in my answer for sure. Perfect. So to jump into the substance, and again, I know this is probably a review because folks have had the language for a while, but I just thought it would be helpful to kind of walk through, especially for those of you who might not have had a chance to spend as much time with it. Starting with Part A of the bill language, which really has two major components. The first is a cap on the amount that a general acute care hospital can charge or collect from a commercial insurer, or essentially employer or individual as well, for facility services, so institutional services specifically, and caps that at 200% of the relevant Medicare price paid to the hospital for that same service, with a start date of January 1, 2028. There's two exemptions included for that element of the policy. So critical access hospitals have a blanket exemption, which I think you mentioned is not quite half, but a good number of Maine's hospitals at this point are critical access hospitals. And there's also some language about an exemption for financially distressed hospitals, again, recognizing, and we've talked a lot about hospitals in Maine and the financial headwinds some are facing, and we do know that there are some hospitals that are on tenuous ground. So we wanted to include a recognition of that and a path forward for exempting them from this cap that would actually, reduce immediately revenue that they'd be bringing in. And the office in the structure of the bill now is charged with developing a methodology to define and apply financial distress, specifically using audited financial data from NHDO to have clarity about what kind of the source of that data would be. But with some flexibility to think about a range of different metrics and how they could be considered. And then growth caps are the second component. So this element of the policy would apply to all general acute care hospitals and critical access hospitals, and would limit the amount that each hospital's prices can grow to the market basket adjustment used by Medicare for inpatient and outpatient prospective payment system. Which we selected after kind of looking at options that some other states have used in this area, thinking that the Medicare IPPS market basket adjustment is sort of more specific to input costs for hospitals. It's designed to account for the expenses around labor and equipment and other input costs that hospitals are facing, as opposed to a more general measure of inflation. Some other states do use something like CPI or CPI plus a percentage, but that's obviously sort of a broader consumer-oriented metric. So that's the quick summary. I'm happy to take questions if folks have any, or sort of broader reflections, but then we did also develop a few discussion questions for each of these that we can use to kind of kick off conversation.
I guess, I would be curious what folks think about the cap level specifically. 200%. On one hand, it feels like still a lot, double what Medicare gets paid, but on the other hand, I hear the hospital position that many of them are struggling financially and understand that is probably too low for this bill. So, I don't think we should cap it at 500% of Medicare or 600% Medicare, where we do see some charges. But is there a right place to implement a cap, or is there a justification for hospitals being able to charge 5 or 6x Medicare?
Yeah, Jordan, if you want to weigh in, and then Randy, it looks like put his hand up right after you.
Yeah, just building off that, I think really important question is, I know you guys have done a lot of empirical work on this and really tried to dig into it, but just out of curiosity, if you have some like high level metrics or kind of background on like what percentage of services right now would be impacted by it. And then I know also, this has gone into effect in other states, but if they had documentation on their relative percentage of services that would have been impacted by a cap at this level. Just curious if that is something that you guys have on hand or kind of have rough knowledge of at the moment.
Yeah, I don't off the top of my head, because I think percentage of services impacted would vary quite a bit by hospital, depending on payer mix. I think that the commercially insured segment of the market in Maine is a little over 30%. But we know there's variation in utilization, particularly, I think, the Medicare group isn't necessarily comparable. So I'm happy we can take that back and take a look, and we may be able to look at a hospital level using some rough data on payer mix to get a sense of kind of proportion, maybe of net patient revenue by source that's impacted. And to your question about work in other states, I do think that they've thought about breadth of policy and level. So 200 is towards the top of what other states have done when they've done service level caps, but they have also been applied in more narrow contexts. So in Washington, for example, they have a price cap in their public option, and that's lower at 160% of Medicare. But the two states that have passed state employee health plan price caps have both gone with 200%. Randy?
Yeah, so as you mentioned earlier, I'm newer to this group, and on the eve of the hearing on this, I'm just wondering why we're asking this question now, and maybe this has been discussed at a previous meeting, but I just found it interesting that we're having this conversation with this committee the eve of when there's going to be a hearing on this tomorrow. So I guess I'm kind of curious on the timing of this and what the role of this committee is, and shouldn't this been discussed earlier, I guess. But like I said, I'm new to this group. I'm just asking the question of why are we asking this question now?
Yeah, so we presented on this policy at the November meeting, and we showed some rough estimates of impact, and I think had some discussion then. We didn't pose the question, what level of cap, and I think the feedback that we got from some members was no cap, that there was opposition to the concept of having a cap on hospital prices, which we hear and understand, but I think we wanted to make sure that we were more specifically posing the question to give an opportunity for feedback on where a cap could be set. But we did sort of review this concept and discuss options for where a cap could be set at that meeting that we held at the beginning of November. Yeah, Dr. Evans?
Dr. Evans can dial in my phone.
Yeah, sorry, we've got you muted again. I think, however you
everything.
There we go. Perfect.
I'm used to everything being at the bottom, and it's
the Zoom versus transition is
right. No, I was only going to make the point that other states have had caps, and I guess the determination as to what the cap should be is something we'll have to determine. But I think that we have to start somewhere, and I don't see a reason why we shouldn't begin with the caps that we are suggesting in our report thus far.
Thank you.
I'll just go on the record if I may, Mr. Chair. I think this whole concept is flawed in its premise. And so there is no amount that I would ever be comfortable setting. It's based on an assumption that there is excess revenue that hospitals are currently earning from commercial payers that can easily be given up without really creating difficulties for those hospitals in the delivery of services. So I think I've put it in writing, I've said it, and I feel I will say it again. I don't see the need to participate directly in this conversation because the concept of caps, of mandatory caps on commercial payment, when we're already capped by federal and state government through Medicaid and Medicare, is not something that we can be okay with. It is flawed in its premise from my perspective.
I guess my pushback would be that the current methodology for commercial payments is a flawed methodology. I mean, we're relying on carriers to negotiate often opaque, sort of seemingly arbitrary discounts off of a charge master. And I know that's less true with DRGs these days, so it's not true across the board. But I think defined logic in the current payment methodology is kind of hard to identify. And I think using a Medicare benchmark at least brings more transparency into the payment methodology. I think Medicare has a pretty robust process for determining what it reimburses for charges. I think it's up for debate whether or not that's adequate to cover the charges, but we're not talking about reimbursing services at Medicare. And on the excess revenue piece, I think part of the reason for this is because at least I personally believe there's opportunities on the efficiency side to cut costs out of the system. I think we saw this at Northern Light over the last year where they improved their revenue position by approximately $150 million. And I know Inland Hospital closed, but they didn't close that $150 million gap with just the closure of Inland Hospital. And so they were able to cut a lot of expenses out. I think there is a lot of room, and I'm not running a hospital, so I'm not going to venture to guess where that is, but I do think the current market dynamics where we have a very consolidated delivery system in Maine has allowed for price increases that are not always, let me phrase this, I think it has allowed for price increases as the easier lever to pull versus focusing on efficiency in the market, because frankly, you can't negotiate prices down when you can't sell an insurance plan in the state of Maine without including one or two large systems in your network. It doesn't give you much leverage to control price. And there's lots of academic research, and maybe Maureen can speak to this, showing that consolidation is highly correlated to higher prices within a market.
I know there are hands up, so I'll hand off to others. Randy?
This 200%, and I kind of echo what Katie is saying too. And I am the president that was at Inland when it closed. And there's a straw that breaks the camel's back. And if you're going to start limiting what we can charge to Medicaid, to insurances, that will be a straw that breaks another camel's back, and there will be hospitals that close. So I'm not saying that to be, like shock value. That's the reality that we have hospitals on the edge right now, and you will close hospitals with this, the way it's written right today. And that scares me because of access to our patients. I do get concerned about access, and we're not even considering that in this conversation. I also work for Northern Light, which was just mentioned, that we still have a ways to go. I mean, yes, but there was cuts, there was all kinds of efficiencies. I'm overseeing, essentially 3 hospitals now. There's things that you can do, but we're still not out of the woods. We still have to be prepared for 34,000 people being off main care because of the reductions at the federal level. And how are we going to pay for that, let alone how do we pay for this with it's like a grocery store. If somebody dictates that you can only charge $3 a gallon for milk, then eventually you're going to stop as a grocery store selling milk, right? I mean, so services will close and hospitals will close with this. So I'm very concerned that I understand we got to do something, but for whatever reason, I've only been on this committee for, a short period of time, but it seems like you're always on, like, hospitals are the evil empire and we're just blaming them, and it's always about them versus let's all sit down. Let's get the insurers, the providers, and the state government together and actually come up with a plan that works for everybody, where everybody has a little bit of pain in this versus just saying it's all hospitals. And that's what this does. It points the finger at hospitals and it doesn't point the finger at anybody else. So that's my comments.
Thanks, Randy. I know Maureen and Kate both want to weigh in, but I just want to speak to a couple things you said. I think first, in terms of thinking about access, we have done all we can in terms of looking at examples in other states where prices have been capped, at looking at examples from literature about impact to try to assess that. And I think, again, that's why we wanted to bring the conversation back to this group again and say, if 200% isn't sustainable, can we talk about what is? Because I do also want to say, these aren't charges to insurers, right? That ultimately they're charges to people and to businesses in Maine. And that I also think there's a breaking point coming in terms of how much can be absorbed. The other piece is in terms of focus on hospitals. I know you are newer to the group, so I want to say we started the conversation about policy priorities for this office back in the summer of 2024. We looked at a wide range of what we call policy domains, and then we used a pretty transparent, I think, clear rubric to determine where we wanted to focus, thinking about feasibility of options, think about where the office could contribute in ways that other departments or other parts of state government are not, and thinking about the impact. And this was one of 3 policy priorities that we landed on. We also, in our office, staff the Prescription Drug Affordability Board, for example. So we are thinking about other policies, and I don't think that this is to say that this is a focus. It's certainly not that anyone is trying to demonize hospitals or to point the finger, but I also think the data is pretty clear that this is part of the challenge and that we have to have a conversation about it if we're serious about affordability. With that, Maureen, I know you've had your hand up for a bit. I'm happy to pass it to you.
Thank you. I just wanted to weigh in to highlight from the national perspective that looking at referencing Medicare is, and a multiple of Medicare, has been actually something that a number of states have started pursuing. We saw 13 states last year introduce legislation at varying points of a multiple of Medicare, some as low as Medicare. It did not pass. Some up to 300% of Medicare. But just to share that when NASHME, my organization, has talked to state officials about why they're moving in this direction, it is what Trevor referenced. It's an interest to move from a discount from a charge master rate to cost plus, and recognizing that Medicare does have challenges about setting what costs should be, but they do strive to cover costs of their patients. And again, I am not suggesting lowering the 200% number, but there is a rational sort of rationalization behind using Medicare, and it's not just happening in Maine. We do anticipate at NASHB that this is going to be a move that a lot of states try to take, and it is pretty popular at the state employee health plan level, but it is broader than that in other states. So I just wanted to reference that it is not unique to Maine, and it is being highlighted as a way to try to address cost and the opacity of how charge masters get set.
Thanks. Just a question for Maureen. You just said that reference-based pricing is not limited to state employee health plans in other states. It's broader than that.
In Indiana, it is.
Has it taken effect in Indiana yet?
So Indiana has had multiple different laws that they put forward, and I can't remember the year. I can follow up and get it for you. But Indiana has set a reference to Medicare at 268%, I believe, in the aggregate. And then they have found that that was not achieving the goals that they want. So they did pass another law to set it at a per service level. So that the former piece has gone into effect. The latter piece has not been implemented yet. The other thing that Indiana has done is require hospitals to offer employer-based coverage and opportunity for direct contracting at 268% of Medicare. So it is at a larger market than just the state employee health plan. But you're correct that at a per service level, that hasn't been implemented yet. But I was referencing that states have been introducing this and exploring this policy.
Thanks, Maureen. That is helpful. A good reminder, because I know I've certainly focused more on the recent Indiana law, but a little bit of history there. Kate?
I just wanted to touch on, because people have been referencing access, and we released data from some polling that was conducted in Maine recently showing around 7 out of 10 people are delaying medical care or treatment due to cost. And so I just want to emphasize that affordability barriers are access barriers. So if the prices are making it prohibitive for people to access treatment, then I think that is a real access problem that people are already facing. And I also just wanted to point out that while this policy seems largely to, looking at hospital pricing, there is state regulation and federal regulation for insurance company pricing that it does exist, and the Bureau of Insurance does do a comprehensive rate review. And so it's not, I don't think anyone's saying hospitals are the only entity that should be regulated within the larger healthcare market.
Yeah, I would just add, from the employer perspective, employers price capping makes a lot of employers nervous. They just generally, I would say, don't like the idea of putting price caps anywhere. It's not necessarily what they consider to be a free market tenant, obviously. I think what I'm hearing from them, and pretty overwhelmingly, is that they don't believe that healthcare is a real free market anymore. And that's why I think, Randy, go back to your grocery store example. I think it's sort of a flawed analogy, because if a grocery store raised their price of milk to 6x their acquisition cost, somebody can go to a different grocery store. But in healthcare, where you have sort of like let's be honest here, we have two really dominant systems that get to set prices. If you don't like that price, you're not going to get medical care. I think we all agree you need to get medical care. And the whole market dynamic has been so subverted by the amount of consolidation within the system that we've ended up with really, I think, really out of control price growth. And at least exactly what Kate has just talked about is people are no longer getting care because of the cost. I mean, in Maine, we have the fourth highest family deductibles in the country. The average family premium is $25,000 in this state. People can't afford to get care. And that right there, we already have a huge access challenge. And I think we can sit around the table and continue to have these conversations, but we've been talking about this for as long as I've been involved in this. I mean, for the last 15 years, at least these conversations have been taking place. And, you know, I think we have had good conversations, collaborative conversations around quality, and we've seen meaningful gains in quality, but price just keeps going up. And there has never been a really good mechanism to keep it in check.
Dr. Evans?
Yeah, just to follow up on that, yeah, we've been talking about access in our healthcare system for as long as I can remember. And not, I don't think the intent is to just poke at the hospitals, but the reality is that is where the largest drivers of cost are coming from. We used to see, well, I think we continue today to even see hospitals as being, healthcare as being in the form of only a brick and mortar. The more facilities we build, that's going to improve the access. That system doesn't work anymore. So we spend a lot of time talking about access in our strategy discussions, but the changes for people are not being easily seen. So how we need to go forward is to put that on the table, and we have to talk about the costs associated with hospitals. So people who look at it from the standpoint of how do they get the care that they need. Take for example, I'm a little concerned about what's going to be happening when more hospitals become for profit. We're already having that is Maine Health. So I think once that barrel starts to roll, you're going to see other hospitals joining on that bandwagon. And what we need to do, or continue to do, or even look forward to, is how can we make access more available to people, but we have to keep it as cheap as we possibly can. We can't continue just to build hospitals. Something has to change, and what we're doing is not getting the results that we need, and it's only going to get worse because of an inept Congress, in my opinion.
Thanks.
I think too, like on the access issue, you know, if this is done well, right, there are going to be a lot of exemptions here. Nobody wants to see a hospital close. I think that's the whole point of the exemption for financial distress. I don't think hospital closures are an acceptable outcome of this bill to anyone. I think I see this more as they're drawing a line in the sand saying this is where we need to start to move to. And we can go slowly, we can go considerately, but ultimately we have to do something on what's driving cost. And it's like setting sort of a future goal that we're all trying to work to hit. I don't think it's about being punitive. I hope it's not perceived as being punitive, although I'm sure it is for some folks. But maybe it seemed like you were going to say something.
Is that limitation?
Yeah.
I think so. So I think it's really important. I think we all share the goal of affordability, but I think there is there's a difference in how we're viewing what it takes to have access to care. And I'm the first one to say, when you have good coverage, you are more likely to access the right care at the right place at the right time. I do believe that. but there seems to be a desire to support coverage over access. And our hospitals and FQHCs are the only entities in the state that consistently provide access to care for our most vulnerable populations. They're the only ones. And so, and unless I'm wrong, someone can tell me that I'm wrong, but as such, targeting them, maybe not targeting the FQHCs, but you're targeting the very entities that are mission-based, to Dr. Evans' point. Right now, they're mission-based and using what they have to provide care to all of their communities. So there's just seems to be a disconnect in the desire to have affordable coverage over at the expense of access, or potentially at the expense of access. And so that's one point. Second point, another absolutely flawed presumption as it relates to this conversation and to much of the work that has been done nationally is that hospitals operate as independent entities. In many cases, including Maine Health, we have one tax ID number for our entire system because we are ensuring that the services that make some margin are supporting, or the hospitals that make some margin are supporting all of the entities that make no margin, including behavioral health services, which loses money every year and has for decades. And Spring Harbor Hospital hasn't had a margin in at least a decade, for example. So this notion that you can protect a hospital because it is financially not viable actually is a flawed notion, because we operate as ecosystems. And if Maine Medical Center is the entity that gets cut based on a bill like this, it has an impact on the entire system across the state. So I will stop talking now, but I needed to say those two.
Yeah, on the first point, I would say, I do think we're trying to think through that, and that's the reason why we wanted to put primary care and behavioral health care floors in as part of this bill. I think we've had that conversation a few times with Maine Health, but certainly with others too, saying we're losing on these services, and that's the reason. So, and I know we'll get more into this later on in the conversation, but we're trying to ask the question, okay, then how do we better support primary care and behavioral health care directly? Because those are important to all of us. So I do think, recognize that. I think as it relates to the financial exemption, I think great if we want to kind of transition to those questions. I think there are options to, for example, think about metrics at the system level for finances, not just hospitals in isolation. And part of the reason, that we wanted to approach this through some time to work with stakeholders and sort of do a rulemaking process likely was based on conversations in this group where we've talked about the need for there to be multiple years of data potentially that we're looking at because of volatility year over year, and where we've talked about needing to focus on several different metrics that, there's probably not one that we pick as the way to determine what degree of financial distress a hospital is in. And I think probably some consideration of system level finances are part of that too. So I'd love to hear if you think there are ways of getting at that question of not looking at each hospital in isolation, but trying to think sort of more broadly about a system's finances.
It's got to be the state. I mean, Maine Medical Center and Eastern Maine Medical Center are supporting every hospital in the state. Every critical access hospital uses their services. We have behavioral health patients who go to Acadia because Spring Harbor is full. I mean, it is genuinely an ecosystem. So I hear you, and I recognize that cost reports are the data that you've been using. We actually post our audited financial statements so for the public on our website for the very reason that cost reports they provide hospital specific and non-comprehensive views into hospital finances. So I am
I would just say we have been using audited financial statements collected by MHDO. And I think we had a conversation about looking at hospital finances. I think it was the summer meeting and had sort of landed on wanting to do that. I think there are times when we're not able to because the data simply doesn't exist in audited financials. But I did just want to recognize, I don't think we've been relying only on Medicare cost reports. At times, it's the only option because it's the only comparison to other states, which is why I know the MHA has used it as well when talking about financials. But I do think the bill language as it is references, like I said, specifically MHDO data and looking at audited financials for the reasons that we kind of discussed in that meeting over the summer.
Because I was on, I know you work very closely with NASHB, and the NASHB webinar, the NASHB website is primarily based on.
Yeah, and that's, I mean, it is the one national source of data, like I said. So I think every time that I've seen someone make a comparison between hospitals in Maine and hospitals elsewhere, I think that's the source they've used because there's not. Sorry, some hands up. Kevin?
Yeah, this is kind of a comment and a question. First, I agree that I think we all are looking for ways to improve affordability. So I think that's something that we can all agree on. And then the other part of it that has been talked about at various points is the desire to move away from the discount off charges. And I think there, correct me if I'm wrong, but I think everybody is amenable to getting away from the fee-for-service structure that is not efficient and gets us at loggerheads at times, whereas a more fulsome, holistic approach that includes up and downside, risk sharing along certain parameters with good guardrails in place. As an insurer, that's our job, is to take the insurance risk, but there should be some performance risk that's identified, and so there are proven ways that I think we can arrive at much better reimbursement structures or payment structures that align incentives and can really help providers, particularly in the cyclical nature of the healthcare economy that we have. Just thinking back to COVID, how awesome it would have been if there were capitated payments. It would have eased a lot of the burden, smoothed things out. In any event, I wonder what thinking went into the drafting of this in terms of considering alternative payment arrangements as a vehicle for getting to that end goal of both affordability and accessibility.
Yeah. But did you want to just make clear? Yeah. So Kevin, I think there's a couple answers to the question. I think the big picture one is, I know we talked about those 3 policy priority areas that we outlined, and one of them being aligning incentives for efficiency and quality, but viewing that as something that the office now in particular is involved with as part of rural health transformation program, sort of that's created an avenue for some of those conversations, though I think they can be broader too. I've always viewed that conversation, I'd be very interested in your feedback on this, Kevin, as more an area for collaboration, for convening people and talking through challenges. I don't know that anyone has come to me and said there is a change to law or a legislative approach that's needed in order to facilitate more of that. What I've heard more is, how do we talk about getting commercial payers on board and aligned with what public payers are doing, for example, or just finding ways to facilitate that. So in that sense, I don't think we directly tried to speak to that in this piece of legislation, though I welcome if you think that there are, like I said, statutory changes, I guess, or changes in law that are needed to encourage moving in that direction. What I will say, and I know we touched on this before, but I think non sort of claims or fee-for-service-based payments between a carrier and a hospital wouldn't necessarily be capped under this structure. I think there would be the opportunity for there to be arrangements for performance-based or outcomes-based payments, for example, as a supplement to fee-for-service. So I do think there's some consideration there in the sense that I don't think that this approach precludes carriers and providers working together to pursue those kinds of alternatives. It's just that it's something that I also view as taking some time, right? And that there will need to be lead time and a lot of conversation. And so I view this effort as complementary in the sense that we know the majority of payments unfortunately aren't flowing through APMs right now. They're flowing this way. We do feel like there is a time-sensitive affordability concern for consumers. So can we get something moving to at least get a handle on these prices while we kind of work collaboratively and ideally in my from my perspective as well to kind of move away from this structure and towards different forms of payment that do a better job kind of rewarding quality and outcomes as opposed to volume, because I agree there's a lot of benefit there. And happy, like I said, to follow up if you do think there's specific legislative changes that could help facilitate that.
Kevin, can I just ask, like, I mean, I think I agree with you. We need value-based contracts that have both upside and downside risk. I mean, you're in a position to be negotiating those. Have you made progress in implementing downside risk contracts? I'm sure that's something you've asked for. What is the
Yeah, Trevor, it's a fair question, but it really takes multiple years of working collaboratively to get there. I'd like to be able to snap my fingers. I think everybody would to get to that point. But it is going to take some, we have to walk before we run. And the other part of it is, we're a rather small payer in the grand scheme of things. And so the volume that we have is subject to, greater volatility than, say, some of the other payers, especially when they have a whole national book. So not to complain too much, but it is a difficulty that we have to work through. So, I mean, right now, we're happy with, DRG and case rate arrangements, and look to the near future when we can have some gain sharing, again, with the alignment of incentives and gain the trust and experience to then introduce up and downside arrangements.
I mean, I hear you on the walk before you run. That makes sense to me. But I've been hearing about ACO agreements that are ostensibly these kinds of value-based arrangements for well over a decade now. And I mean, I think we haven't seen those agreements to the degree many are even still around. They haven't really bent the cost curve. And I guess it's just, from my perspective, the affordability problem has gotten so acute that, like, how much longer will we ask consumers and employers to watch the industry walk while we take on 10, 15%, 20% premium increases and folks can't afford to get care?
So I think this is the right conversation actually to be having. And there are a couple things that, I mean, if we had the opportunity to collaborate, and I just went back because I think what I did not understand prior to today was your belief that you're direct, and I think it's fair, your directive, that you have to come up only with legislative solutions. To me, this office would be far better served if it was able to do two things. One, to monitor data, to identify data, look at trends, and then to bring the stakeholders together, I think, as this group happens to be one, to look at what potential solutions are reasonable. Because I think Kevin raises something that is, we all believe that we need to move towards, we need to, and it has been a long time we've been talking about it. So what would it take to actually have risk-based contracts? And I can tell you that at Maine Health, we have developed our own risk-based contracting. We have two entities that some of you are aware of, two primary care practices that operate differently. One's a direct payment model and the other operates as a capitated model, but we haven't been able to get our insurer to actually easily support those outside of the fee-for-service environment. So insurers need to be part of that conversation, and then Kevin can certainly weigh in there. But this is the right conversation to have around how we get our arms around improving the cost of care while maintaining the quality and access of services that as a state enjoy today.
I guess I would just say this is a conversation we have been having, and we've been asking for this for decades. I mean, we at the Alliance tried to get employers together to pursue capitated orthopedic bundles, and we were essentially told no by providers in the markets, and ultimately found a partner in Spectrum Healthcare to be able to deliver those risk-based bundled payments. We had very shortly, and I say we, but I'm talking about CareHealth, we did try to do it ourselves, and we were told, well, no, we're not going to do this. So we hired a vendor to do it for us.
Contract with us. So Trevor, I mean,
that's because we can't get on the same page around value, right? It feels like we can either get the risk and pay through the nose for it, or we can get nothing. I mean, what we want is affordable healthcare, and like I agree this is an important conversation to have. I don't think we should give up on this conversation. I think this is where we need to move, but it's a conversation. It's not a new conversation. I mean, I'm so happy to see what Trellis is doing. I think it's awesome that they're moving to capitated payments. We've been talking about the need to move primary care to capitation for years at this point. And it's just, I think, where I get really frustrated is the pace. And we've been talking around this issue for so long at this point, watching the situation get worse and worse and worse, that now we're at the point where we have to consider really significant legislative action because the stakeholders just have not done anything or done enough to address consumer and purchaser affordability challenges. It's unfortunate that we're here, but I don't know how much longer we can hold our breath and hope folks figure it out for us.
I will just say, I know others have had their hand up since before this conversation started. I think it's a valuable one too, and I know we've talked about it periodically at these meetings, sort of the concept of how could we be involved here and what's a role that we could play to be helpful, given that we all know and acknowledge this isn't the first time anyone has thought about getting together and trying to solve these problems. And I think this conversation makes clear there's big issues to work through. So I just want to reiterate, there's a reason why that's on one of the 3 policy priorities and what we wanted to focus on. And I do see a future for doing that. I also think that, again, when the legislature created this office and in my interactions with them in the time that I've been leading this office, that there is an appetite for them to want us to bring ideas back to them and to want us to take action more quickly and more directly. So again, I see them as complementary, not in opposition to each other. I know there's complications with that, but that's my goal. And I don't want to, I'm certainly not saying that that's not an important conversation to have, or frankly, I do think that that's the discussion that gets us to a sustainable, well-functioning system in the long term. I just think that it takes time and that there's a need again to at least bend the curve while we work towards that. With that, Amanda, sorry, I know you had your hand up for a little bit, but would love to turn it over to you.
Yes, no problem. I don't mean to derail the momentum of the conversation after Kevin's comment, but I just had a comment about your kind of sub-bullet point on this slide about specific metrics and benchmarks related to financial performance. And the Shep Center for Health Services Research out of the University of North Carolina, Chapel Hill, has developed a financial distress index for rural hospitals. I don't know if you're familiar with that, but it could be a basis for thinking about what would make sense in Maine. They look at, they can use the index to predict 3 like indicators of financial distress, including closure. And they have a ton of variables that kind of fall into 4 different buckets. So market characteristics, government reimbursement, financial performance, and then organizational traits. So like we were discussing earlier, is a hospital part of a system or independent? Mark Holmes leads that research, and their work is funded in part through the same mechanism as the Maine Rural Health Research Center. So if you ever want to be connected to them to discuss their work, I'd be happy to help make that happen.
That's great, Amanda. Thank you. And a good reminder, I know in the last year or a little less than that, there's been a few different academic institutions that have put out different methodologies for trying to identify financial risk. And we've taken a look at those as they've come out, but it's a good reminder to return and take another look at those methodologies and think about the factors they're considering and how to apply them as we think about tackling this question. So thank you. And yes, I would love to take you up at some point. We'll reach out about a follow-up. Always nice to have the conversation about how they landed with the methodology they did too. Great. Dr. Evans?
Yeah, I'm on. Okay, can you hear me?
Yep, we can hear you.
Okay, just to follow on, when I was reading through the report, there was a notation made about the financial metrics, and if we're going to be, if we want to get things going in the right direction, I think it's incumbent upon everybody to be transparent. And I just don't feel that it's happening. As a matter of fact, I know it's not happening. It's important for the Office of Affordable Healthcare to have that information available, because the metrics tend to not be standardized across the board. So if we're going to look at what we can do to make things better across the board, we need to have that information. And it's people are willing to sit down as partners, but if you're sitting down as partners, you got to be transparent and you have to put everything on the table so that you can come up with the right decision that's going to be in the best interest of everybody.
Thank you. I appreciate that. I was going to say, I think the MHDO audited financial statements are helpful in terms of their standardization. There are some complications because I know that there are differences in terms of looking at consolidated statements versus non-consolidated between the systems, because they have sort of different structures for some of their hospitals. To Katie's point about, I know MeMed, for example, can be contain other entities in ways that some of the other systems don't. So not perfect apples to apples, and there certainly are challenges with that. But that has been, I think, kind of our go-to in terms of comparison. I will say, we would love more detail. There is a lot that's sort of lost in those in some cases. So I know we've talked about what are drivers of increased input costs, and the reporting is high level, and it's not always easy to kind of track those metrics. So when I mentioned cost reports, that's one area where there's a little bit more granularity, and we have had some opportunities to work with Maine Health Data Organization at times to sort of better understand that or ask if there can be clarification around data submission. But I agree, visibility is really helpful to us and just understanding what the real picture is. And I think having opportunities to ask questions or get clarification. But we do benefit, I think, from MHDO's long history working on that reporting and a lot of engagement that they've done. Thank you. So just, I know this has been a robust conversation. We've moved around to a few different parts of the policy. Maybe I can briefly touch on the last item here, and then we can talk a little bit more about the other parts, just to check if anyone had thoughts about the IPPS market basket as a metric sort of for, I say inflation here, but really input costs, to check and see if folks have ideas about the application of that. Understanding it may be similar to CAHPS in terms of overarching, thoughts on the notion of the policy. But before we move on, anyone have anything on that point? Okay. As always, we can always come back. Part B, sorry for a wall of text here, but this is the section that addresses changes to prior authorization. So this is largely focused on regulation of insurance. What it does is sort of amend the language that currently applies to fully insured plans that are subject to state regulation to add a new requirement around prior authorization that was based on a bill that's still pending, that was developed, I know, by Maine Medical Association and others, and that we talked about as a top priority for providers around the length of validity for prior authorization for treatment of chronic conditions. The language isn't identical. We did shorten this a little bit, and we also changed the language slightly. There was language in the original bill around the length of the condition or a number of years that I know I struggled to sort of understand. So for simplification, just went with a structure with a period of 1 year for initial validity and then renewal not less than every 2 years after that, with some language that if a new treatment protocol is introduced, that could be sooner. So if a biosimilar is introduced, for example, that a carrier would have an opportunity to check in and see if it would be appropriate to move a member over to that. And then there's also a restriction on applying prior authorization when there is a change. Sorry, all. Hopefully you can still hear me. I think our camera turned off for some reason. We'll work on that. Great. Thank you, Amanda. So to kind of help with transitions of care to make sure that folks can continue on a treatment. But again, made a small change to this language, which I don't think I noted here, but just clarifying that for prescription drugs, they need to be on the formulary of the plan when the consumer enrolls, again, to remove a little bit of a kind of concern and lack of clarity that folks have. So those are new requirements that apply to plans in the fully insured market. What this bill also does is use the access to service level price caps as sort of an inducement, a carrot, if you will, for self-insured plans, which can't be regulated by the state. And says if you want to benefit from those service level price caps, if for hospitals to be required to provide them to you, then self-insured plans must also comply with the restrictions on prior authorization that exist in current law for fully insured plans. So that is that new requirement that I noted, but also a turnaround time for decision in non-emergency cases, a prohibition on retrospective denials, and a requirement that appeals be conducted by a clinical peer. So a little bit of a creative use of the structure here to be able to reach and try to, as I said, induce kind of participation and compliance with this in a market that otherwise the state isn't able to apply any of these restrictions on. So moving on, I'm not sure we'll have as much conversation on this, but just wanted to ask again explicitly if there were additional provisions that folks would want to suggest for this section, other ideas of what could be helpful. Or the other piece that we just thought we'd say is we've really looked around and tried to find, again, evidence-based or data to think about estimating the claim cost of these kinds of provisions. The research base just isn't there on broad kind of application of prior authorization policies. It has been studied, but usually in very kind of specific cases where there's some consideration of a cost benefit analysis. And I know that this was part of the kind of discussion around the original bill that ran last year. So we thought we would pose that as a question to the group if any members have feedback on thinking about how to create those estimates or understand what the cost would be in terms of additional claims costs for members.
Keep talking. But there was a fiscal note, which is why it's on the appropriations table. We thought it was ridiculously high, but I assume you looked at the methodology for that fiscal note.
I don't think we've seen methodology for that.
We haven't, because we asked.
Yeah.
Because that would be the place to go. I mean, there has to be methodology. It's for the state employees' health plan, so I assume we could get it.
We could look into it and ask. I do think that that's one carrier's, estimate. So I don't know that we would presume that that would apply across the market. But we can.
Yeah, I, as I said, I think we thought it was ridiculously high, given how this is a fairly narrow bill, but it would make a big difference for patients in particular. who have chronic conditions.
We'll keep looking. If anyone, I know this is a big question, so I think if folks want to mull on that, and if it occurs to you, oh, I read a paper on this that might be relevant, I love that. Oh, sorry, Kevin, go ahead. Didn't mean to cut you off.
Yeah, no, I don't have any sources for consideration, but I would just indicate that we're opposed to the approach of the LD 1496, which has been folded in here. We're all about trying to smooth the process and make it less administratively burdensome. I think between folding in the earlier discussion around alternative payment arrangements and ways that we can approach the payment for care, and this fits within that, because I'd like nothing better than to have a partial cap or a full cap and delegate the oversight of prior auth to providers themselves. Short of that, right now we have a rather disjointed system. So a multi-year blanket authorization could really blow a hole in the side of any health insurer, and we've certainly seen 24 and 25 being extremely challenging years for us from a claims cost perspective. So this kind of policy, absent the other things that we need, whether it's access to Health InfoNet, at least getting ADT information from every hospital, which we do not get. So oftentimes the authorization is the only indication we have of something happening. So I much greater comments and longer commentary, but I'll stop there, just indicating that I get the intention and I support the desire to try and make things easier to get people the right care at the right time. This just has too many unintended consequences.
Thanks, Kevin. If I could, something that I thought about, I know we sort of raised this question several times, looking for areas of opportunity here, because I understand both sides of the equation, but also, have said before that this just feels like such a pain point for both patients and providers, that we wanted to take steps to do something about it. And I think in thinking about this particular structure, where what we're talking about is an approved prior authorization for treatment of a chronic condition, and with language where if there were kind of changes to available treatment options, there would be the opportunity to apply prior authorization. Again, I'm just trying to understand from the carrier perspective, what would be the scenarios where prior authorization being applied would be, a cost saver to you for a chronic condition. You're not thinking about necessarily initial prior authorization, where it might be about looking at the options for treatment that are available, truly just from the perspective of trying to understand a little bit better sort of what the justification for needing more frequent renewal opportunities is.
Well, I mean, some of the issues arise in terms of, let's say a provider has a prior auth that's multi-year, and there's a change in the person changes. Well, take for instance the policy. Now all of a sudden we have a preferred site of service with lower cost imaging. Well, the only way to really intercede is to have the conversation at the point of the authorization, just as one example. So how do we in this current non-system that we have environment, what traction do we get in order to help the consumer, help the patient, as well as help the plan, which helps all of the premium payers, including that patient? Again, this is a rather blunt instrument to what has to be, a more detailed approach that can't really be done in statute. We've seen the effects of other prior authorization, hammers, I'll use the word, and it's been, challenging to say the least in terms of how we can manage costs on behalf of all our premium payers.
That's fair. I appreciate, the feedback. And I think I wanted to ask the question because I think if there are some specific circumstances where it feels like there could be an opportunity to say, if X arises, that should be an exemption. I'm happy to consider that. But guess I just, feel similarly that while I would love to see carriers and providers come together and solution for this collaboratively, we haven't seen that necessarily across the board. And again, trying to find ways that are less blunt. We did give a lot of thought to the application of this and how it would be applied. Again, just not broad brush painting all prior authorization, and glad to consider other nuance. But
here's here's a concrete example. Let's take the rise of biosimilars. So if a year ago someone had a 3-year prior authorization for Humira or Stelara, well, we would not have the opportunity to move them to a much cheaper biosimilar. And that alone, for our small health plan, saves about $3 million annualized by moving to biosimilars, which are just as effective. So we talk about cost controls, you're essentially taking away a huge management component by saying, nope, you got to live with what you approved 3 years ago. It really doesn't make much sense.
I just completely agree with Kevin. I mean, we said just as much on the other prior authorization bill. We have these new drugs coming out, and we have to have some ability to move patients on them. It seems like you've tried to address that in this bill, which I really appreciate. I think employers generally don't want to see their ability to prior auth restricted. I mean, beyond just new drugs coming out, I think hopefully we can all agree there is overtreatment in the healthcare system. Some of it's driven by providers, some of it's driven by patients themselves that want things and demand things. But somebody has to be the adult in the room and say, no, this is not good for your health. There's risk here. And I worry about prior auth taking that adult out of the conversation, and we're all paying a lot more money and people are being subjected to things. I do think there's tons of room for improvement on prior auth. Absolutely. It gets used inappropriately. I think a lot of the time it is hard to do legislatively. And I think from the employer perspective, it's hard. I see it sort of like a gimme as this part. We're trying to make providers' lives a bit easier, knowing that the price cap side of it will make their lives a little harder, right? I mean, I guess I'm only really supportive in the sense that it's trying to reach some level of compromise here.
Yeah, I was just going to say in direct response, Kevin, that we did try to tackle that by including language about, I think the language might be new treatment modalities, but I can double check exactly what was used and would welcome your feedback if you feel like it's not capturing scenarios. But the intent certainly wasn't to say when there is a scenario where there may be a cost saving option that's just as good clinically for the patient, that shouldn't be a moment where the carrier can check in with the provider. I think that's totally appropriate. So we did try to include language, making sure that was, an exemption essentially from the policy, and would welcome your feedback on that language if you think it could be clearer. Okay. Keep moving to part C. So this is looking to increase investment in primary care and behavioral health care. This creates a minimum floor that carriers would need to use for reimbursement of primary care and behavioral health. We chatted about this a couple meetings ago as well, sort of scoping that out, because I know there can be very broad definitions of primary care. We really envision this as applying to a core set of evaluation and management and counseling services, looking at data and also having some conversations with providers, our understanding is those evaluation and management codes tend to be the bulk of revenue for a primary care practice. So we felt like that would be a way to set some clear parameters that would be implementable and sort of understandable for everyone and still capture and influence a significant amount of revenue coming into those types of providers. And use Medicare for a benchmark here as well, looking at 110% of the relative Medicare rate. Really think about this as a floor, something we thought about is floor versus, is it where payments should be? Maybe not, but thinking about the absolute minimum. And we actually know there's quite a few behavioral health providers in particular that are paid significantly less than 100% of Medicare, in some cases where primary care is as well. So that's a little bit of the rationale there. And then this section also includes some language. I know something folks asked as we were thinking and developing this policy is sort of how do we make sure that consumers will benefit from this? And so there's some language developed to some extent with feedback on adding some granularity to the data that the Bureau of Insurance collects when they do rate review, so that they can be, equipped to ensure that there's benefit. I think their position would be between medical loss ratio requirements and the scrutiny of rates that they apply at this point that, there's sort of a natural ability to capture savings, and then clearly for any self-insured plans that comply with the requirements, those savings kind of accrue directly to the employer since they're paying claims themselves and paying a TK likely on a fee basis. But so that's just a little addition in thinking about how can we make sure that the focus is on consumer benefit here and that there's a really close eye on what's sort of being saved and how that's translating into premiums for consumers. So similar to the conversation about the caps, wanted to start with the question and open up, if not 110% of Medicare, are there other thoughts on where the payment floor should be set and what would be impactful and meaningful for payment for primary and behavioral health care?
I'm just curious. My philosophy as it relates to this is not dissimilar to my philosophy as it relates to the caps, but I would say we're totally in agreement that these are underpaid and we need to flip the entire charge master for everything. And in fact, we have a consultant who's working on that for Maine Health right now. That being said, do you have data on the number of providers who are paid, especially in primary care, at less than 110%, who take Medicaid patients? Or I guess this is specific to commercial, but FQHCs are definitely way more than 110%, and our contracts are above 110%. So I'm just curious at who the target audience is and which patients they take.
Yeah, we can't do a count of providers. There's no data source that gives us that level of granularity. What we looked at for this was HCCI data, their database and some reports that they've done on payment rates and volume for primary care and behavioral health services, which do only represent, a portion of the employer market, but give at least a sense of where prices are falling. And it was not insignificant, the additional payments under 110. If we were set at 110% of Medicare, this is in those slides from the November meeting, so I shouldn't say numbers off the top of my head, but it was in the tens of millions for both primary care and behavioral health care, with more investment on the behavioral health care side. That's where we saw current relative rates on the lower side. I have heard from community behavioral health centers in particular that that's an area where they were paid less by commercial payers than either Medicare or Medicaid.
And we do have a parity law that should be so,
yes, but defining what constitutes a similar service is complicated. Yes, Dr. Evans.
Yeah, just a clarification for me. It said in-network. What about out-of-network?
Yes, thank you for that, Dr. Evans. That's a good clarification. This is set only at in-network rates, and part of that is because of the sort of like mechanism being used. We felt that this would need to be enforced by sort of visibility into contracts. I'm happy to take back and think about the out of network piece. But I also think we were interested in encouraging more participation in networks. And so I think we also want to be careful that we're not creating an incentive that encourages, finding the right balance. Because I think particularly on the behavioral health side, we know for independent providers, that administrative burden is part of it, but I have also heard feedback that payment rates are part of why they tend to be more reluctant sometimes to join insurance networks. So we kind of wanted to focus on in-network payment in part in hopes that that might encourage more providers to say, actually, the cost benefit analysis is good enough here that I'd like to go in-network, because that would help with the out-of-pocket costs, of course, for members, consumers as well.
Thank you.
Thank you for catching that. I should have been more specific in my description here. Other note that I'll just bring up in conversation with providers over the past several months, we got some feedback with concern about the idea of a floor and, questioning, well, if there's a floor set in statute, would insurance companies potentially use that as kind of an excuse to actually lower their payment rates? Would they treat it as though that's the set payment rate and come down to it? So, we've been kind of turning that over and thinking it through and wanted to bring it back to the advisory council in case folks have thoughts about that. One idea would be find some way to say the greater of the Medicare reference rate is the floor, or some rate at the current moment or in the past as a way to protect maybe against that. But again, interested if folks have thought. My initial reaction was a little bit, I have the sense that probably carriers are already leveraging as much of their market power as they can to kind of keep rates low. But I do think it's an important question and one I'd love to hear thoughts on if anyone has. Okay, I think that was the end of the slides that I put together. I'm happy to kind of pause there and stop sharing and bring folks together on the screen if there are, bigger picture items that folks want to raise. I will say, hearing your comment from earlier, Katie, understand and respect that folks in the advisory council are on, have different opinions, I think, about the concept as a whole. So hear that, but wanted to give an opportunity to kind of have the conversation and pose the questions, but just want to acknowledge that.
I appreciate that. And I guess after this bill is done and this process is, this sort of point in time has moved to wherever it's going to go, it would be really helpful for me if we had a conversation here about process, because we didn't have discussions about the what here. You presented your analysis, you presented data, and then you presented your solutions, but we didn't have discussions about whether there were other solutions, or it really didn't feel like it was a collaborative conversation. So that's the piece I think you're seeing a lot of reaction to with some of us here. And after we move beyond this bill, it would be really helpful, I think, if we could, everybody has shared goals around improving the health of this state, and providing affordable care is providing an affordable being a key word is a huge part of that. And so I hope that we can wind up in a place in this group where we are providing input and having those kinds of conversations, and not just reacting all the time to the work of the office.
I'll say, as the chair, I'll take some responsibility for that. Feedback is well received. I guess I just, I think maybe we need some clarity on sort of what this group is meant to do. I mean, my understanding of it was that the office would basically decide sort of where they want us to focus and what they want to pursue. And we're here to advise them as they move through that process. maybe it is more, we're supposed to all work together and tell the office where they're supposed to go. I'm not sure what the answer to that is, and I can look at the statute. I don't know, Meg. Yeah, so that's sort of the perspective that I come into these meetings with, right? Is Meg is sort of running the show, and we're trying to give her feedback on what we think she's doing. But I will, again, I'll take a little, I'll pull all of the blame for that as the chair.
I appreciate that. I guess regardless of, I mean, that point is well taken, and we're one big small state. We are not a whether the employers like it or not, we're not in a competitive environment in Maine. And as such, I think that's a positive. And I think that we could do a lot more working collaboratively than ending up fighting each other across the road. So, and that feels like it's where we've wound up with this bill. And that's unfortunate to me. So I hope that we, for the future, might be able to look at other opportunities and other processes so that we can at least know where we're coming from and why.
I think and appreciate that, Trevor. I will say I have a similar read, I think, on the statute, that it is written in a way where it is an advisory council. It's not necessarily a body that's determining the direction of the office. And I think we kind of reiterated that in the rules of operation or whatever we called it when we all got together. I think we talked through that, though I know it was a while ago, and it may be a good moment after this to like revisit that and do a little bit of level setting. I especially acknowledge for new members, they've kind of jumped in at a time when there's been a lot going on. So I totally agree. I think sometimes we're just challenged by timing as usual, like things move slowly and then they move quickly. But I'm happy to take that back and think about just making sure we're sort of walking through things and being more deliberate about opportunities for conversation on ideas in this group.
I appreciate that. And I guess I would say, if you think that this is the most successful way to operate for the state and to meet the mission of this organization, then keep doing. I mean, that's fine. I just think I guess my perspective is there's potentially a better way to do it, and one that would create a lot less discord in the process.
Yeah, I think I am mindful of balancing collaboration and wanting folks' input. And I think especially, obviously, there is so much nuance and depth to each of these areas that chances to sit down and talk about details like data and how we're interpreting it or how we're thinking about just problem solving are really valuable. At the same time, I didn't come into this role and don't necessarily think about the work as solely consensus focused. I think there are times when conversations are hard and people are going to strongly disagree, and that doesn't mean that it's not worth pursuing or worth bringing. So I am trying to think about that, and I just want to be clear that that's the way that I've tried to approach the role to date and the way I imagine we will moving forward. But I also, like I said, I'm glad to kind of take the feedback and think more about making sure that we are giving everyone an opportunity to provide that input or share that in advance and not feel, that something has come up unexpectedly or that there wasn't an adequate sort of pathway for providing feedback. Yes, Dr. Evans.
Well, this is my personal opinion. I don't see this group as being adversarial. I think we're all in the same boat, and we want the best results for the people of the state of Maine. And I don't expect everybody to agree on every item or detail, but I think it's in our best interest as an advisory council to do the best job that we can to make it easier for the Affordable Care Committee to do their job. We're going to disagree. I'm going to say something that's stupid. Somebody else is going to say something that's stupid. Stupidity has its place. So I appreciate everything that everybody has said. And I don't want to be surrounded by people who are just going to agree with me. Over my career, I learn better by listening to other people's input. And even though I may not agree with that input, I have a duty to listen because that person may be able to change my mind. So I don't want anybody walking away from here thinking that they don't matter or their opinions don't matter, because they do. And it's going to make us all better in the long term.
Thank you, appreciate that. I take that back, and next time I make some silly mistake. Is it stupidity is okay?
Yep. You got to make one stupid mistake at least once a day.
Got it.
I hate to rush about this conversation, but with the 15 minutes we have left, I did send along a letter, and the genesis of this is really from the HHS committee hearing where Meg did a presentation, what was it, a week or two ago, and they basically said, what does the advisory council think of you pursuing this? So I tried to draft a statement. It doesn't endorse the specifics of the policy. It basically says that it's worthy of discussion, which I feel like it is. I tried to acknowledge that there are struggling hospitals in it. I would like to see if we can get a vote in terms of like actually presenting this position to the HHS committee members. I think, as we just heard from folks, it's unlikely everybody is going to agree, but if folks felt so inclined, perhaps we could have like the Supreme Court sort of minority attachment opinion to it. I don't want to be fair to them, but I guess I wanted to get your thoughts here before hopefully can take a vote on this.
Aren't we, I mean, testimony is going to be up tomorrow. So I would imagine we all have opportunity to testify to the committee. I can't endorse the bill as it's drafted, but endorse some of the principles in there. So it gets a little difficult to have a binary, thumbs up, thumbs down.
Well, I think that's exactly why I chose the phrase, we believe the idea is worthy of consideration, which I tried to keep pretty, as neutral as possible. And we've been talking about this for a long time. Nobody has said this is not an idea worth consideration, I believe, in these meetings. Dr. Evans.
I would agree with Kevin. I saw the letter that you drafted. I'd leave it as it is.
Shall I move for a vote? How do I just?
I know we
all in favor of the council endorsing this letter, say aye.
Maybe we should do raised hands.
Raised
That
hands,
makes it easier to-
count.
I mean, honestly, I haven't had time with the letter. I've been in back-to-back meetings this whole week, so I'm not going to vote one way or the other.
Staying is fair. We can do that. Okay, got it. And do folks want to do opposed? Yeah.
Opposed, raise your hand.
Trevor's, excuse me, not Trevor, Jordan is not voting. Yes, you're good, Jordan. You're an ex officio non-voting.
Am I missing anyone else that's not on camera here?
Not who is on and off camera, all the advisory council members who are with us.
Okay. Gives you some clarity if you get this question again.
That's helpful, yes, thank you. Okay, anything else? Thank you for coming. I know it's a busy time. Appreciate it. Appreciate the conversation. And I do think we'll give some thought to the next meeting, maybe doing a little bit of a level set conversation about what makes sense. Thanks all.
Thank you. And thank you for bringing this. I wish we'd had this conversation.